You can play your slides.
Very good morning to you all. My name is Dr. Raj. I'm a practicing orthopedic surgeon in Singapore. My topic today is I'll be talking on lumbar facet cyst. Uh, so this topic I came across because now generally in degenerative conditions we don't pay much attention, but after doing or started doing endoscopy, since we have a better view, and lumbar facets started to interest me. Uh, Thanks, ISUBE, for inviting me for giving this, and I'm very glad to join the meeting. I don't have I have no disclosures, and this is the hospital that I work in. It's uh, General Hospital. It's the Jurong Health campus of the National University Health System. We cater to the west of Singapore, so we uh, around 12% of the Singapore population. We of together it's around 5.5 million. So coming to my topic, the common pathology of lumbar synovial cyst, it is associated with it's a good close association instability, resulting in spondylolisthesis and scoliosis. The most common location of the cyst, you all know, is the lumbar spine. And the lumbar spine, it is at lumbar 4-5 level, where the maximum movement. The pathogenesis remains difficult, but largely it is related to abnormal facet joint mobility, which is obviously secondary to degenerative changes. When you look at the evolve or the evolution of the facets, you can start with the degeneration first, with the formation of lumbar cyst, and finally ending up with when you look at the pathogenesis, it usually starts off with the anterior column, where this gets degenerated and there is vertebral end plate changes. This reduces the loading bearing capacity of the anterior column and hence shifting the putting on to the column involves the accumulation of the fibrocartilaginous substances, weakening of the capsule, and cyst formation. So, like I mentioned, the majority of the cysts appears at the alpha 5, the most mobile region, and the common concurrent pathology associated is spondylolisthesis. The management of the cyst, well, you have basically two types, basically your non-operative management, which is observation, physical therapy, and but rarely it results in cyst regression. Usually these things are very conservative care. So when you come to um, types, especially with facet cyst, one is your percutaneous aspiration, the other one is simple decompression, and then compression with stabilization of fluid. You look at the percutaneous aspiration, obviously, it's got the highest recurrence rate because you're not removing the facet, and this can still continue to cause the symptoms and compression of the nerve roots. So approximately one third. So when you come to the decompression alone, which is the most used, involves laminectomy facility, and the resolution rate is supposed to be around zero point 0.9. That's all. And the last option is obviously fusion, which definitely takes care of and assists, but and the when you come to the classification of the cysts, there are two main classifications. One is your neurosurgery research group classification, which was developed in 2018, in 2020. The neurospine surgery classification, quite simple. There are two main types. It basically involves two parameters. One is your canal compromised by the cyst, and second is clear. So the canal compromise more than 50% with a spondylolisthesis is obviously greater. And the Rosenstock classification takes into account the location of the cyst. So if you have a medial, lateral, or a lateral, it goes to a higher grade. And with the spondylolisthesis, obviously, it comes to the highest grade, which is type 4. So this is an example of a grade 1 according to the neurospine surgery classification. So in a grade 1 cyst, you have less than 25% canal compromise and no. Grade 2 will be 25 to 50% with no listhesis. And grade 3 would be more than 50% with no, and so on. So grade 4 would be less than 25%, but with the spondylolisthesis. So the presence of spondylolisthesis, which is more than 15%, obviously comes into the higher. And highest grade would be more than 50% with a spondylolisthesis. So the neuroscience classification, the highest risk for cyst recurrence is obviously with grade 4 and grade 5 cysts, uh, or a simple decompression. And recommendation was actually for 4 and 5 should be a concomitant stabilization. Grade 1 to 3 are a good candidates for decompression. The Rosenstock grading scale, like I said, it location of your cyst. What they found in their study is the recurrence associated with steeper facet joint angle, presence of spondylolisthesis, and even the location of the cyst. So this is the facet cyst angle when you measure line drawn parallel to the disc, and so anything above 50 degrees got a high chance of steep angle and high chance of recurrence, obviously causing more spondylolisthesis. But all these studies are for open decompression. How about when we do it endoscopically? Is it different? So when I looked at the literature, actually, there's not much literature on the compression with endoscopic techniques. And that is something that is More studies are required for it. So I'm going to go through some of my three cases of three different approaches. One is a standard side interlaminar approach, standard the right side interlaminar approach, and one far lateral or a paraspinal approach. So first, I'll go through some of the settings that I do in my OT. So this is a setup that I have. So the table that we use, our is the proactive table, and then your standard arthroscopic tower, which we use from Smith and Nephew. And this is how we position. So if you look here, the patient is lying on the table and is around it's flexed to around 20 to 25 degrees. So the interlaminar space. We have our tower, which is on the, if I'm standing on the left side, the tower is on my right side, opposite. And then in between comes the C arm, and then on the left side, I have the monitor here. And we have a platform here where all the equipment, the bird, all the pedals that come on top. And we start off with the lateral so that this is perpendicular to the floor. And we go on to AP to mark portals. We can also use the Wilson frame for flexion in case the product is not available. So this is my standard marking. So I mark the midline first. Then I go on to the median pedicle line, which is a medial border of the pedicle. And again, depending on the pathology, if I'm going through a laminectomy, I mark the working portal first. So on the left side, this will be a working portal. So I mark it on the lower end of the lower lamina on the medial pedicle line, and then I take 2.5 to 3 centimeters higher, and that will be my viewing portal. So I find that this is quite easy to reproduce, quite easy to teach, rather than that if you want to pass on to your juniors or who are as a fellow. And then we start off with the techniques, and that's my this sheets, which is your orange portal as well as the yellow one. Orange is for the viewing portal, and the yellow one is for our working portal. And I find these sheets quite helpful as if you want to retract the nerve root, and it helps us a lot as a retractor as well. So again, when you come to the interlaminar side, like I said, I marked on the medial pedicle line and the lateral as well. Then we start off by talking on the spinal laminar junction. The steps are usually the same. Subfacial working space initially, clear off the muscle. Then we create laminar working space by drilling and with various we go on to do a superficial ligament. We start off with a proximal laminotomy, then IEP section. On to do a distal laminotomy, deep flavor, and that compression. If you want to do discectomy, then retraction of the nerve root and then. So I'm going to start with a video here. This is a standard approach for a very small facet cyst. So this is a standard left side handling interlaminar approach. So I'll just go through with this video quick. So this is a patient who presented with left side radiculopathy for a facet cyst. So I start off with the clearing of the exposing the proximal form. And with a combination of burr, so we can use standard diamond 4 mm of burr and a combination of kerosene ronges to clear the proximal lamina. And then coming to IAB, combination of physicals as well as so this is the IAP as well as SAP, and this part, lower part, is the lower part. This is your distal lamina. So again, the distal laminar resection is partly by also use chisel, and we use kerosene ronges to take out the deep phlegm. And once the deep phlegm is out, and we find that the cyst in total. In this case, we got a full cyst. We were able to remove the whole cyst as a. and the patient can go home the same day or the very next day and quite well. So the next one is my right-sided approach. So in the right side is a bit more challenging, especially learning curve. Can be done in three methods. One is standard patient left side, and then you go the contralateral, what the previous speaker was alluding to, where you go over the top. The second is standing on the right side itself, but holding your scope, your scope port actually becomes. And the other one is what we call the southpaw grip, where you stand on the right side, but you switch your engine.
Yes, Papa.
So when you mark the portals for the right side, slightly different from my left side because of the anatomy. So the portals, as you can see, the viewing portal and your working portal is a little more caudal, and it's closer to the upper lamella. And then intraop, I mark it with the needles on the medial pedicle line. And top end would be on the distal lamina rather than the spinal lamina junction. And as such, I'm going to show you the video on my right side of a more complex process. This patient presented to me with right side radiculopathy. So this is L5S1 facet cyst. So L5S1 with minimal spondylolisthesis and complex cyst, which is on the right side. Hence, decided a simple decompression from the right side. So this is me standing on the right side. So I'm just going to fast forward. So that's your caudal part. So right side, you find that there's a bit more work to do for the muscle. It's a lamina viewing. So we start out by clearing up the muscles on the right side. And once you start clearing, and then your ligamentum flavum, which is yellow ligament, comes into view, and identify the caudal lamina, which will come into view soon. Yeah, so once you identify the caudal lamina, then we start with our drilling of the caudal lamina. And remember, the caudal lamina is thinner, and you might be able to breach through the caudal lamina as it happened in this case. So once you do that, then it goes, I go on to the ipsilateral facet, AAP, IAP, and I start drilling. And the burr actually helps us to clear some of the soft tissue as well. So it kind of functions as a shaver. So you can see the caudal lamina is exposed here, the ipsilateral facet, SAP and the IAP. And once you do that, expose a bit of the cranial laminotomy as well. And once you do that and you remove the flavum, you can see that the red one is actually the facet cyst. That is not the nerve. So you can see the facet cyst comes into view. And this is something I want to stress this because facet cyst is something which on the dorsal aspect of the nerve root. So it pushes the nerve root ventrally. So in case of facet cyst, it's more complex. The first thing that you will be noticing is the cyst and not the nerve. And the nerve root is actually deeper to that or ventral to it. So it's a good idea to have a good look at the MRI before you start off so that you're safe. So once you identify the cyst, the next step is actually to get all around the cyst. That means you get lateral, medial, cranial, and medially. That identify your nerve elements first before you start the removal of the cyst. You can see on and off the burr will come on. So this helps us to preserve the bone and to take minimal bone out as possible. So once you do that to remove again a part of the flavor, and you can see the medial side aspect is the dura, and on the lateral aspect is actually the cyst. So Once you identify this, I come along with the dissectors, create a plane first, and then the big guns come in, which is mostly the Harrison ranges. So again, I'm clearing on all aspects of the cyst. You can see now this is the lateral aspect of the cyst. Again, creating more space, and I'm going to remove it piecemeal. Just fast forward it a bit so that it's. So I'm using the retractor there to move away from the cyst and then removing it piecemeal. Again, I'm removing dissecting the medial aspect so that it's free from the neural. So you can see this is still the ball is not the nerve. The nerve is still on the ventral aspect. It's not. So again, removing some of the phlegm again, and then removing the cranial aspect. So with a combination of Harrison rongeurs and curettes, you can achieve and I want to go and forward to this area where, and that is a lateral aspect of the cyst. So once I do that, then and removing piecemeal. Okay, so I'm going to come now with there's some hemostasis there with the nerve hook. And I'm going to lift this. So that is a cyst wall being coming off. And then you can see, you will see the nerve root coming in now. That is a nerve root. So that's a traversing nerve root that is coming into view now. So this is the fact that I want to stress. The cyst is actually lying over the nerve root. So once you remove the frame, you will be seeing the cyst first. And once you start removing the cyst, then you see the nerve onto the ventral aspect. So now the nerve root is, and then you're more confident about where your neural elements are. Then you complete your the rest of it. And so at the end, you have the dura in the middle, and then you have the traversing nerve root, which is free. So so the nerve root is free and it's confirmed, and then at the end will be some hemostasis, and then. So this is what I want to stress. So when you look at this picture, the facet joint here and the cyst coming, and you can see that it's actually pressing onto it dorsally, and the nerve root is pushed ventrally. And this is a representation of how the cyst appears on the same level at 4.5. You only see the nerve root. Right. We come, and the last one is a pyramidal facet. And my approach to a pyramidal facet also UBE technique with lateral pedicle line and plus 2 centimeters, so that I will end up on the transverse process, and my docking point will be at the articular process. So I'm going to present this case of a far lateral left side for a pyramidal cyst. This is a young patient who was presented with a severe radical in the F4 distribution. And you can see the facet cyst there, which is on the compressing the nerve root, and lateral or paraspinal approach, UBE technique. And so again, I come with the outro, clear the soft tissues, and you land on the facet joint, which is a whitish structure there. Once you identify the facet joint, I go ventrally and go. That is the ventral aspect. So once you identify the ventral aspect, then you come in with the burr. In this case, I'm using a diamond burr to just to protect the neural elements just in case. The combination of drill and then hemostasis part of the SAP on the ventral aspect. And in between checking with your C-arm is a good idea to not to get lost. So once you create space for yourself, you will be seeing the flavum element, especially the foraminal ligament at that region. More clearing of the soft tissue there. And once you remove the foraminal ligament, then you can see your foot will come up here. Again, some more of the drilling. So this is your cranial side. This is the medial side, and this will be the caudal, the lateral side. So this is how the IAP, and here will be the SAP here. So once I move the foraminal ligament with the dissector, you can follow the cyst coming into view now. So some more clearing there. So I'm going to remove this foraminal ligament, and then yep, with the kerosene rod. Create enough space for your instruments to go in just enough, so you don't take out too much of the surface. Once you remove, and that the structure that you're seeing there, that is looks very looks like a nerve, but like I said, if you pay close attention to your MRI, and as I said, this usually presses the nerve root dorsally, sorry, ventrally, and what you'll be seeing first would be your spasm. So that is your facet cyst. So the next step, as I told you, is to clear all around the facet, so you create space and identify the stuff. And you can use a combination of your dissectors and create a plane and use a nerve hook. Once you create a plane, then you can bring in your Edison branches and clear. Always a safe technique to use your dissectors first and then bring in your big one. So that is still the cyst wall that is coming into view part. And going to remove that cyst wall from all around. And once I start removing, again, some more to create space, I'll just fast forward this, some more hemostasis. Uh, and now you will slowly start seeing the exiting nerve, which is the or exiting nerve root coming into view. There. So you can start seeing the nerve root there because the red structure is crossing this way. So once you see that, again, I use the dissector to create a plane. So you can see the view that you get with UB techniques, and it's beautiful. And that's why I really like UB for this. You can customize it. You can see the structures very clearly up close, personal. You can even identify the plane between. You can use your dissectors to develop the plane, and then you can even bring in your Harrison branches to do that. So your nerve root is quite free, and I will use more carrots to clear it. And use a nerve hook as well. There you go. And then use your kerosene gently around the nerve root to free the nerve root. Yeah. So in Singapore, getting a post-op MRI is also quite expensive. So we usually go by symptomatic, and both, I mean, the patients are quite like, you can see, once you see the nerve root, you're sure that the symptoms would generally disappear, which is your best technique. So once you identify the nerve root is free hemostasis, then the surgery is done. So again, just to reiterate my point here, if you look at this picture here, this is the disc. So the disc prolapse is coming from the ventral aspect, it pushes the nerve root up. And if I said since the pathology is dorsally, it pushes the nerve root down. So like in the previous video, there's a cyst that will be seen rather than the nerve root. So just a point to note. Of course, you really pay attention to your pre-op MRI. So these are my references that I took for the physics. And the take-home message, UV is a very versatile technique for treating hypertension and for most of the pathology. The approach that you choose depends on the anatomic site of the lesion. And hypertension usually pushes the nerve root ventrally, and definitely pay attention to the pre-op scanning. You need a tailored approach to the patient's symptom and their requirement. If the patient has a grade 5 cyst with a lot of back pain and leg pain, you can consider fusion. You need further studies, especially with endoscopic approach modular. And that I in my talk, and thank you again for inviting me and having me give my talk. Thanks a lot.